evaluation, we always try to describe the comparative assessment between costs and outcomes. For sure, we use the ECO model, as the ECO model talks about the economic, clinical, and humanistic outcomes that we would care whenever we offer different options for our patients in the healthcare system. When we talk about any evaluation process, we have two arms, equation with two arms. So we have input and we have output. In our input, for sure, we enter costs, and for the output, we look for the outcomes which is represented as benefits or consequences. The result, of course, is just to look at the relation of the estimated addition of cost as related to the estimated addition in the outcome of using alternatives. The incremental change is the word or the concept that the decision maker would be looking for in order to build or make their decisions. As Dr. Imad said, we usually focus on main questions that would help in decision making. So first of all, we need to make sure that we're using the best of our resources in order to apply or to implement the interventions. Also, whenever we have many different alternatives, many different options, we need to be very smart in selecting the one, especially when we cannot afford just one option for us. So we need to help our decision makers in making the best of their selection. The hope from any health economic evaluation is to maximize our outcomes while reducing or minimizing the costs. When we come to pharmacoeconomics is the application of the health economic evaluation within the pharmaceutical field. When we talk specifically about drugs or alternatives or whatever tools that are relied to pharmacy. So again, we have the same equation with two arms, and we cannot call any analysis pharmacoeconomics unless it take in consideration both arms. So it has to look at the cost and it has to look at the outcomes while comparing two or more alternatives between each other. So once the analysis would focus on one arm rather than the other, it would be called a partial analysis. So it might cover just the cost, and then we call it a partial economic analysis, or it might focus on the outcomes only, and we call it just a clinical or outcome study. Within the overall health economic evaluation or pharmacoeconomic evaluation, we will face and see many different types. In this session, I tried to pick the most common types of health economic evaluation. The first two, cost of illness and cost comparison analysis, are the ones that are considered partial, not full economic evaluation analysis. The last, we would consider them as full because they would take in consideration both arms looking at the cost and the outcomes. So when we talk about cost of illness, here we just measure the medical and other costs resulting from a health condition or a disease. So we usually call it a burden of illness. Nowadays, while talking and experiencing COVID-19, we heard a lot talking about the burden of COVID-19 worldwide, right? So what they were doing actually, they were looking for the different costs that would, the different types of costs that would raise up because of that type of illness. Okay, so we may look at the medical costs, which include diagnostic tests, physician visits, drugs, and medical supplies, whatever. And the non-medical costs, which might take in consideration according to the perspective of the analysis, the patient perspective, the societal perspective, governmental, or any local institution, okay? And also it may include the productivity loss, which might be impacting the patient or the caregivers, taking in consideration absenteeism or presenteeism, okay? Here is just a simple example of cost of illness, comparing between two infectious diseases, Salmonella and Listeria. In US in 2011, so the number of cases of Salmonella was huge, reaching up to 1 million, while Listeria was like 1,500. Looking at the hospitalization, we can see just 20,000 of the 1 million were hospitalized. But when we look at listeria, we can see that almost everyone was hospitalized. So here we can see the burden of listeria as compared to salmonella. And whenever we look at the specific costs, let's say the medical costs and productivity losses, we can see that the cost is half for listeria as compared to salmonella. But looking at the average cost per case, we can see that the effect of listeria was much higher as compared to salmonella. Here, we can compare between two diseases, and we can look at the burden of each disease. And here we can now make a better decision whenever we have a potential to select a preventive measure. So we would focus on listeria more because it would be a burden as compared to salmonella. Here I come to the cost comparison analysis, and again, it's a partial type of analysis, and it will look at the cost of different alternatives. Okay, it will not take in consideration the outcomes of the treatments or different alternatives, but it will comprehensively list different types of costs, even the intangible cost, which would look at the pain and suffering of the patients or communities. It would help for the people who work in the budgets. So for any hospital or for any institution where we care about our budget, we need to have the list of the costs summarized in one sheet. So here we don't care much about the outcomes, but we list the cost of each alternative that we can use for any problem. Here's again an example for cost comparison and economic implications of commonly used originator and generic chemotherapy drugs in India. Here in this example, they were listing, sorry, I think it's not obvious, it's very small font. But here what they did, they looked at the different regimens used as a chemotherapy for cancer patients, and they were comparing it with their, let's say, generic brands, okay? So they were just listing the cost of the brand and the generic without looking at any outcomes related to these regimens, okay? By this comparison, they can look at just not effectiveness, just comparing the two costs. For the cost minimization analysis, here we come into the full economic analysis. In this analysis, we compare the cost mainly under the full assumption that the outcomes are equivalent, okay? So as Dr. Imad thankfully said, the clinical equivalence mandates a clinical evidence, which should be relied on clinical trials and, let's say, evidence-based studies or evidence-based decision, it should be. So the problem with cost minimization analysis that it's not highly applicable, because in rare situations, we can just assume that the effectiveness is similar or exact between the different alternatives. So we can use it just to compare between generic, branded of drugs, generics and the brands. And this is what we usually see in our institutions as we try to use the alternative or use the generic instead of the high costly brands. Also, we can use it in order to measure the cost of same medications in different settings. Let's say if the patient can take the medication in outpatient setting and then to compare it with the inpatient setting. Okay, here we can assume, of course, the same effectiveness, same outcomes, but different settings and different supplies, so different costs. Here is another example, talking again about the chemotherapy regimens in Japan. I like to pick this example because, as you see, they divided the intervention based on the effectiveness. So they separated the regimens according to the inclusion of certain drug, oxaliplatin, and they assumed that the presence of this drug would affect the effectiveness of these regimens. So whenever they did the comparison, they were comparing the cost between these two regimens, let's say, okay, because they have the same effectiveness, and then they tried to compare these three regimens because they also have the same effectiveness. But they didn't try to compare between these two different groups because they have different effectiveness outcomes. As you can see here in the table, effectiveness should always be comparable, okay? The only thing that we need to compare or focus on would be the cost. Moving to another type, which is the cost-benefit analysis. In cost-benefit analysis, here we try to give a monetary value for our cost, the cost of our alternatives, as well as the outcomes. So giving a monetary value is not an easy thing or easy duty to look for the outcomes. Let's say if we can look at the mortality rate or morbidity rate, it's not very easy. The decision would take a lot of efforts and long time in order to be made. How we can value a human life? How we can value a lower quality of life for 1 year or whatever time period that we are interested in. So this type of analysis, even it exists and it can be used and applied for some types of problems and diseases and the use of some alternative, but it needs a lot of work and the decision won't be that easy in order to be taken. Okay, and it will, of course, according to the perspective of the analysis, whether we're taking the patients in consideration or thinking about institutional, governmental perspectives, the full story would change and the analysis and using of models and parameters would change accordingly. Here is just to demonstrate the parts or the sections within the cost-benefit analysis. We would see the ratio between the cost of our alternatives and the benefits given the monetary value. So for the cost, we would look for the direct medical cost or even the direct non-medical cost. The change would be here in the benefit. So in the benefit, we would look for the direct benefit. So we would look at the direct medical savings of using a preventive program or using a certain type of treatments, as well as the direct non-medical savings for our patients or on our institutions. Same, it would be the indirect benefits related to the productivity. So, and we can apply many different approaches like the human capital or willingness to pay according to the different perspectives that I just mentioned. And it might also include the intangible benefits, taking in consideration the patient preference, pain, and suffering. So as I said, it's not easy or straightforward, and it would take many steps in order to give the monetary value for our benefits. Here is an example looking at the reduction in clinical outcomes associated with vaccination using a cost-benefit analysis. First of all, what the authors or researchers tried to do is to identify the clinical outcomes that they would give the money value for it. And then after estimating it, of course, they would look at the cost per person vaccinated, okay? So they will look at the cost for each vaccine, direct or indirect, and then they would give the money value for the outcomes each that were specified from the previous step, okay? At the end, they can do, or what they did here, they performed a sensitivity analysis in order to look at the cost-benefit ratio and to decide whether the alternative was, let's say, better adopted as compared to the original used or the approach that was applied before the vaccine, okay? Coming to another type, which is the cost consequence analysis. Here we would say it's same, comparing the health intervention with another alternatives. It takes in consideration the list of each alternative separately. So it would include all cost for all options and all outcomes for all options. This is good for to be given to the decision makers who would at the end decide between the different alternatives, and they may focus on the important aspects of one option rather than the others. So it's not that easy because you have to include everything related to the different options and the available options that you have, either locally or even broadly, internationally, whatever the level that you are looking or trying to look for. The cost effectiveness analysis, I will take about it briefly because I know my colleagues would cover about it later during today's sessions. Cost effectiveness, actually, for me, I would consider it the very easily applicable method in order to look and compare between the different options or alternatives, because it's unique, because it looks at the cost and it would give us a ratio when it compares the outcomes using a natural unit. As Dr. Imad said, whenever we look at two antihypertensive drugs, we would look at the reduction in blood pressure levels. When we look at diabetic medications, we will see the outcome represented by the reduction in blood glucose levels. So it used the natural measure of the outcome that we would be interested or we are looking within a specific disease or related to a specific medications, okay? So the outcomes from it, as it gives us the net cost divided by the change in health outcomes represented by the natural units, we have a very common incremental cost effectiveness ratio, ICER, and it's usually, you would hear about it a lot today in today's session. Already Dr. Imad talked about it, and here's the expression of it. We just look at the difference between the cost of our options, and we take it over, or we divide it on the effect or outcome of the two alternatives. Here is just simply talking about the cost effectiveness grid. In the cost effectiveness grid, we can look at our outcomes, let's say, easily, and compare their cost and their effectiveness. So if we can tell initially whether the outcome alternative is having a lower effectiveness, same effectiveness, or higher effectiveness, or it's lower cost, same cost, or higher cost, okay? So if our options are within same cost with lower effectiveness, or higher cost with lower effectiveness, and higher cost with same effectiveness, these options are dominated. So we do not adopt them. We just ignore them and we take the original, let's say, choice. We ignore these alternatives. On the other hand, if our options were same effectiveness with lower cost, higher effectiveness with lower cost, or higher effectiveness with same cost, these alternatives are dominant. So we take them, we consider them, because they would give us a benefit as compared to the other original option, okay? So I will leave the cost effectiveness because I know it has a lot of details that would be covered later. Coming to the cost utility analysis, in cost utility analysis, we cannot, in cost effectiveness analysis, we cannot compare between, let's say, different diseases or different health conditions, because the outcome is very specified as related to a type of disease or a health condition. In cost utility analysis, we try to use, let's say, a universal health measure, or that represent the health outcomes that we might be interested in comparing between different alternatives. As Dr. Imad said, we use the QALYs, quality adjusted life years, which is universally accepted whenever we look at the outcomes between different alternatives. So the QALYs, even though they are universal, but as well, we cannot get into them easily, okay? Because we're not looking at the natural measure or the natural value of the outcome. We need to convert it into something else that in which way we can compare the diseases between each other or the outcomes between each other, okay? It might include both morbidity and mortality benefits with medical interventions. Also, it would look at the quantity and the quality of the life years. So it's combined between two, let's say, main concepts related to outcomes of use of alternatives. For utilities, of course, whenever we are looking for QALYs, we need to look for utilities. And from the name, we can tell it's a cost utility analysis. So for utilities, we should know that it can range on a scale from 0, representing death, and to 1, which represent perfect health. Of course, some diseases or health conditions might even be worse than death. So it can also take the minus sign to represent the worsening of the, let's say, outcomes of the disease state or condition. Of course, cost utility analysis is a subgroup or sub-analysis or subtype of cost effectiveness analysis, okay? As I said, it's not easy to look for the qualities because it depends on the utilities or the qualities, okay? Here you can see two depictions in two figures. Both of these figures, if you can see here, is the time in years, okay? So living 1 year with a full quality, we gained a 1 equality, right? It's 1 equal to 1. But looking here, living for 2 years with half the quality, still we gained the 1 quality. So how to compare between two alternatives or two options while we see these huge differences in the quality of life, okay? Even though it's universal, but you need to think carefully whenever you try to interpret the result of such analysis. And always we have to think about the, let's say, the healthcare giver or the decision makers, how they value these utilities and from which perspective they should focus whenever they conduct such analysis. Expression of cost utility analysis, somehow similar to cost effectiveness analysis. We would just look at the cost and then divide it by the difference in equalities. We need always to think about the thresholds in any model that we are adopting, and we need to consider the affordability for the institution or the organization that we are offering the results for. Here's an example of cost utility analysis. In this example, they looked for the special test that look for the adherence to antihypertensive treatment. All of us know that being adherent or non-adherent would greatly affect the outcomes in our patients. So looking at the, let's say, commonly used approaches, and then they were compared to using a special test or measure in order to measure a level of antihypertensive medications in urine. They, first of all, they look at the cost for each option, how they usually check up on the adherence, and then they try to look at the new alternative. They also try to look for the utilities, okay? They try to find what types of the utilities of applying such a new intervention. I cannot go deeply with full details about these modeling and such analysis methods because it would take a lot of steps in order to explain everything. I just like to explain to you how the steps might be like multiple and complex, correlated, and we cannot separate them from each other. Here's my references for the presentation, and I briefly finished talking about these slides, and I'm welcoming any questions.